grand rounds that Kylie Washburn is helping us host. So I want to thank Kylie for her service to the department, and we really appreciate everything you've done with the CME office. Thanks, Kylie. Joanna, do you want to come?
Thank you for coming today. It's my pleasure to introduce you Emily Gale, and she was nice enough to write her bio with big letters, so I don't have to wear my reading glasses and date myself. Emily received her bachelor's degree in psychology from the University of Nebraska-Lincoln in 2006. She continued to pursue her master's degree, and now she's expecting to, she's a PhD candidate with a graduation in August of 2012. Her thesis examines affective changes in child maltreatment survivors during marital conflict. Her interests are child maltreatment, the impact of the internet on clinical practice, and clinical work with children and adolescents. She's with us in this department working on her internship in child and adolescent, with the child and adolescent division rather. Emily's it's been great to have her with us. She has a lot of psychotherapy experience with kids, adults, in substance abuse, in maltreatment. She has received awards for her research work on internet and its implications for mental health. She has published 2 papers, one in the Journal of Behavioral Therapist, another in the Training and Education in Professional Psychology. She has presented over 10 presentations in both national and international meetings. So it's a great pleasure, Emily, to hear from you this afternoon.
Okay, thank you, Joanna, for that very kind introduction. I apologize, I sound very bad, so I'm going to try to talk as much as I can, and hopefully I'll be able to make it through the presentation without having to stop or shorten it. So I'm going to be talking today a little bit about kind of where I started in research, which is the long-term effects of child maltreatment. And really, so I'm much more clinically focused, so I wanted to spend my time talking about what we do with the survivors of child maltreatment when they come into therapy. So just to give kind of the props where they're deserved, I come from the Family Violence and Injury Lab at the University of Nebraska in Lincoln. That's directed by Dr. David DeLillo, who's my primary advisor on my dissertation and on my master's thesis. And really the mission of the Family Violence and Injury Lab is to conduct quality research on family violence that's used to inform prevention, intervention, and treatment efforts. There's a lot of us that have been through the lab over the past couple years, so there's been a lot of different aspects of child maltreatment that have been investigated. When I started in the lab as an undergraduate, which makes me feel really old, we were looking at the relationship between child maltreatment and marital outcomes, so marital satisfaction, whether or not the marriage even survived, and then how happy the people were in the marital relationships. We also were looking at intimate partner aggression and the kind of people that perpetrate that, and if there's any link to child maltreatment in the perpetration of intimate partner violence. Some of my other colleagues have investigated issues such as the linkages between early child maltreatment and adult re-victimization. That's actually the new grant that my advisor has, is looking at re-victimization and what predicts that over the long term. And we can talk a little bit about that if we have time at the end. There's also some of my colleagues that are looking at the relationships between emotion regulation and both physical and sexual abuse and perpetration, and then the assessment of child abuse experiences among adults. I think we've all, in our injury lab, have participated in research on how methodologically we measure child maltreatment and some of the issues that go along with that. And that could be a whole nother grand round, so I won't even get into it. So let's talk a little bit about why child maltreatment is a problem, other than the obvious that you shouldn't hurt kids. So between 1993 and 1994, about 600,000 children were deemed at risk for harm from physical abuse. About 1 million, a little more than 1 million, were at risk for physical neglect, and about 500,000 were at risk for harm from emotional neglect. Just as a caveat before I jump into the sexual abuse statistics, sexual abuse is much harder to estimate. Usually we find that there's larger ranges in the rates of sexual abuse, mainly because this actual sexual abuse, I don't know if you want to call them standards or rules, vary from state to state. They also vary between researchers, so how people measure it really can range from over-the-clothes touching to obviously like childhood rape, things like that. So there's a lot of discrepancy in the literature about how many kids are actually sexually abused. However, the estimates are saying between about 200,000 and 300,000 are estimates of sexual abuse. Reports from CPS, and this is again from I think 2002, indicate a national victimization rate of 12.3 children per every 1,000 children. In 2010, the national rates of abuse, as estimated by the National Child Abuse and Neglect Data System, which is the largest report that comes out on child abuse, estimated there to be about 10 victims per 1,000 children in the U.S. Of those victims, about 78.3% were neglected, 17.6% physically abused, 9.2% sexually abused, 8.1% psychologically maltreated, and 2.4% medically maltreated. So again, some of these numbers may be an underestimate, and that's something to keep in mind as you're working with victims of child maltreatment. So we kind of know that, I mean, everybody knows kind of intuitively that maltreatment is bad, but I want to spend some time talking about some of the short-term and long-term consequences of child maltreatment. So obviously, the most severe consequence that could go along with child maltreatment is child death. And over the past few years, namely the past 3 years, fatalities have increased. So in 2002, about 1,400 children were estimated to have died from some sort of child abuse or neglect. But in 2009, 1,770 children died from some sort of abuse or neglect situation. And that averages out to be about 2.34 children per 100,000 children. Head injuries are the most common cause of death in maltreated children. And of the fatalities, children under the age of 4 are the most frequent victims. In 2009, 1 year and younger were 46.2% of fatalities, and younger than age 4 were 80% of fatalities. So while the abusive acts and situations can range from minor physical injuries like bruises, they can also go to serious disfigurement and disability. There's also long-term health effects. These kids are more at risk for cancer and heart disease when they are adults. Obviously, the head injuries and the brain trauma that might go along with that. Burns, chest and abdominal injuries, fractures, growth delays, mainly from failure to thrive. Lead poisoning from neglectful environments, and failure to thrive or failure to meet developmental milestones as expected. So those are the physical consequences. Psychologically, there's a lot of research that talks about the consequences of child maltreatment. In the short term, there's obvious emotional difficulties such as depression, anxiety, and suicide attempts. But in general, maltreated children experience a variety of detrimental abuse-related outcomes, including intellectual difficulties, impaired physical, social, and psychological development. They oftentimes have impaired language development and impaired cognitive development, whether that's from TBIs or some sort of head injury or from nutritional issues, not getting enough nutrition early in life. They generally develop on a different trajectory than non-maltreated children. They also show more externalizing behaviors such as heightened oppositionality and aggression. Neglected children and really some of the other kids who are experiencing pretty severe abuse at the hands of a parent have disruptions in attachment and various psychological factors such as self-esteem and cognitive deficits. These kids also show in the short term lots of social impairments, which can include being very dependent in relationships with peers or just being very distractible in classroom settings and difficult to manage. So obviously, many of these difficult difficulties, if not intervened upon, extend into adolescence and adulthood. So not only are they having short-term consequences, but the detrimental effects have been shown to extend into adolescence, where kids are more likely to engage in substance abuse, more likely to attempt suicide. For adults, physical abuse is linked to the increase of dating violence, as well as perpetrating violence against one's children. Now, it's not a causal link, but it's just associated. Just want to make that clear. And adults that were abused as children have greater rates of substance abuse and are 4 times more likely to experience a personality disorder in adulthood. So basically, before we get into some treatment issues, it's really important to talk about how severely childhood abuse interrupts a child's development. And understanding that will help us kind of understand some of the treatment implications that go along with this population. So intrafamilial trauma during childhood creates a burden that distracts and distorts from the achievement of typical developmental goals in the childhood and adolescent years. Highly traumatized children often are putting their energies into doing things like surviving or trying to get out of physically harmful situations, or psychological strategies that we know are maladaptive, like numbing, denial, dissociation, or distorting the meaning of an event when physical escape is not possible. So it makes sense that if they're putting their energies into those areas, it's going to be very difficult to develop on a normal trajectory. I think today, I should have said this a little earlier, I'm going to be talking mainly about sexual and physical abuse. That's where the bulk of the research studies lie as far as treating victims. However, the things that I talk about really cut across all types of abuse and even other traumatic incidences that we can talk about if we have time at the end. So for sexual or physical abuse, these 2 types of abuse really sort of disturb the development of a coherent and integrated experience of the senses and of the body. This is, it's obvious that a very immature child, immature in a physical way, I mean, they can become overwhelmed by the unmodulated, uncontrolled, and undifferentiated sensations that occur during sexual and physical abuse. Further, children are often abused by caretakers who are failing in their fundamental task in teaching children how to modulate arousal, whether that's physical or emotional arousal. So again, appropriate and effective caretakers modulate a child's emotional arousal by providing appropriate doses of soothing and stimulating activities, which maximizes comfort and security. It facilitates a child's learning of self-soothing techniques and selectively orients him or her to the external or internal environment. Caretakers ideally help a child to label their feelings. For example, when a child's feeling upset, the mother may say, "You're feeling upset because you missed your friend at school today." And by doing that, the parent is labeling the feeling, describing the experience, and explaining the source of the feeling. And that's really how we learn how to do that with social modeling. In an abusive situation, a child may get hit and then told, "That doesn't hurt. That didn't hurt you." So the child experiences a very discrepant situation between an internal experience, which was pain or however you want to describe it, and then the label that's given to it, which is, "That didn't hurt, that doesn't matter, you don't matter." As a result, the child is confused and may distrust their sensory perceptions and have a limited capacity to describe and accurately differentiate their feelings. And that's sort of a point that I'm going to be coming back to you again and again during our time today. Further, like I kind of alluded to a few minutes ago, abusive caretakers tend to be poor models of emotion modulation, as they generally have limited emotion regulation skills themselves. Parents who are abusive are significantly more likely to have drug and alcohol problems, experience mood disturbances, to have been in trouble with the law, spent time in jail, or spent time in mental health hospitals. As such, they're not likely good models of behavior or emotion modulation. Children instead observe the absence of modulation and the negative effects associated with it, like a dysfunctional family environment or legal problems. Excuse me. These problems with emotion modulation can be evident in abused children as early as the toddler years, where you see toddlers who are highly negative. They also usually have much higher rates of anger and aggression. And in preschoolers, we see a lack of self-control that would be developmentally appropriate in this age group. In older preteens and adolescents, they tend to be more impulsive, likely to engage in impulsive behaviors, including sexual activities and drug-related activities, and have a lot of reactive aggression. So they tend to be the kids that get in fights and are the ones that start the fights over seemingly small issues. In adults, we could talk all day about the research about emotion regulation, but really, usually what brings victims or survivors of child maltreatment into treatment is the problems with emotion regulation. They tend to be labeled as emotion phobic or alexithymic, as it's known now in the literature, having high levels of hostility, anxiety, depression, and problems with anger management. Child abuse also interrupts the development of agency, which is something we know a lot about in the children's literature, which kind of extends into adulthood. And agency is understanding the cause and effect that you play on the environment. This is demonstrated in kids as young as 12 months, and caretakers often play a very critical role in the development of the experience of the self as a cause of events. A caretaker often draws a child's attention to their influence in the environment, and as such, the child learns that, hey, if I need something, this caretaker is going to come help me figure this out. Conversely, a caretaker who does not kind of feed or develop a child's sense of agency by either neglecting the child's needs, being unaware of their needs, or ignoring the child's signals, such as when the child cries, the thing that they learn is that you don't matter or you don't exist to me. So the caretaker becomes a reference point for what's successful. And really what you learn in an abusive environment is that not making any noise or not doing anything is the way to be successful. But as we know, that's not a healthy way to live your life. Finally, on the interpersonal development, this incorporates the management of feelings, kind of like we've talked about just a couple seconds ago, and incorporates that into the relationships with others. And it's been found to have 3 key parts: learning and implementing interpersonal models for establishing relationships or schemas, learning how to resolve conflict, and developing flexibility in interpersonal expectations and behaviors. And what we know is that relationships with parents, siblings, and other caretakers create the first models for relating to others and are used as a template to guide expectations and prime behaviors in the development of relationships that follow. So obviously, abusive situations create problematic relationship patterns and attachment in children. This leads to problems throughout the span of development. In childhood, children who are victimized are associated with negative social behaviors such as peer rejection and bullying. In adolescence, they're prone to aggression, social avoidance, as well as increased delinquent behaviors and early sexual activity. And logically, adult survivors report significant interpersonal problems ranging from sensitivity to criticism, inability to hear others' points of view, and being too controlling or submissive, being inappropriately assertive, and being insufficiently sociable. So all of these sort of disruptions in development lead to rigid schemas that are applied to everyone regardless of their situation or the information presented by the other person. And the survivor ends up with this schema that if I need help, other people aren't going to help me, which leads to, again, increased feelings of depression, can exacerbate any PTSD symptoms that would be present, and really increases that sense of, like, I'm in this by myself, I'm alone. So key goals in treatment are to involve helping the survivor develop alternative ways of relating to people and developing a sensitivity to the diversity and the nature, character, and context of relationships. Okay, so the leading model for treating adult survivors was developed by Marilyn Cloytra. The most recent edition of her book, which is it's called Treating the Interrupted Life, published in 2006, and her main sort of thesis is this idea of a resource loss model. And the resource loss model is a way of defining trauma, vulnerability to trauma, its psychological consequences, and the characteristics of effective intervention. So she defines psychological trauma a little bit different from everybody else, but she has a lot of empirical support for the way that she does things. So psychological trauma by Cloytra is defined as a circumstance in which an event overwhelms or exceeds a person's capacity to protect his or her psychic well-being and integrity. So it's a collision between an event and the person's resources, where the power of the event is greater than the resources available for effective response and recovery. So the trauma is actually a very complex relationship between an event and a response. So I'm just going to kind of go through these three parts and talk a little bit more about why they're important in treatment and how they're addressed. So, psychological trauma. So child abuse represents a major trauma as the children's internal or personal resources are limited by the fact that they are little. They're little kids and they're not fully developed. So their levels of cognitive, affective, and physical development place significant limits on their ability to recognize, avoid, or escape abuse. They really cannot get away from it. They're likely unable to fight back against an attacker or to provide for themselves in cases of neglect. They also tend to be naive or confused by sexual abuse, which sort of perpetuates that cycle of sexual abuse. It's a secret, it's confusing, I'm not going to tell anybody about it. That doesn't help the child get out of the situation. In addition, the external resources are far more limited than those of adults. For example, if an adult experiences a rape or a car accident, they're more likely to have a place of safety to recover or a social support network to rely on for care after the fact. Children, however, do not usually have a choice regarding who they live with or who they can rely on for care. And in fact, the person who's supposed to be caring for them and the child is relying on is most likely the one committing the crime against them. So getting any sort of intervention requires an adult, and thus children are often rendered helpless in the face of sort of an overwhelming trauma. So the resource limitations of children confronted with sexual and physical abuse lead us to define child abuse as a trauma in all of its essential characteristics. Children who are abused are individuals who are helpless in the face of repeated, unavoidable, and inescapable transgressions against their bodies. A child's resources are no match for the immediate and consistent threat of a physical or sexual assault by an adult, particularly when that adult is a parent or a caretaker. So the resource limitations the child experiences in confronting the trauma are really defined by the child's life stage and yield a circumstance in which the child rarely succeeds in neutralizing the threat. Once the trauma has occurred, its presence creates a cascade of resource losses that continue through the course of the trauma, so however long it lasts, and have consequences for much longer after the abuse ends. So many psychological and social developmental opportunities and advances are likely diminished or negated as a direct or indirect result of the abuse. So this may include a loss of a normal caretaker relationship, which we know is integral for a normal child development. Resources such as food, basic care tasks, or other more complex tasks like going to school, learning language, anything like that. So these developmental requirements require contributions from the caretaker, the family, and the community. And as previously mentioned, these are likely not accessible to children in abusive situations. Recovery from the abuse requires repairing these resources. Without the aspect of this treatment, adults are likely to experience, they're still going to have functional impairment if we don't go back, and kind of address some of the problems that were created in development. So the first thing that needs to be addressed is healthy attachment. And this is definitely a resource that obviously is lost in an abusive relationship, but it's really one of the more devastating aspects of child abuse in that the abuser is also the caretaker. It's been well documented in the literature that the attachment of a child to a parent or caretaker creates the basis for learning the essentials of living. And again, that could be a whole nother grand rounds topic. But from this sort of healthy attachment and relationship, it springs effective agency, self-definition, and autonomy. It provides sufficient safety for the child to explore and learn about the world in a safe way. It also works to help increase their confidence and self-esteem. In a normal caretaker relationship,